relatively uncommon in pediatric age group, it requires careful evaluation. The abducent nerve, which innervates the lateral rectus muscle, is vulnerable due to its long intracranial course. Lateral rectus palsy produces impaired abduction, manifest as esotropia, diplopia in older children, or abnormal head posture. We report a case of a sudden onset lateral rectus paresis in a 14-year-old child. A 14-year-old girl presented with sudden onset of right gaze deviation towards the nasal side. She also gives a history of fever with headache for 1 week. Lab report showed elevated viral titer and being treated for typhoid. On examination, in primary position, 15 degree of esotropia was noted. Extraocular movement showed mild restriction of abduction, dextro elevation and dextro depression in right type, with the rest of the ocular movements were normal. Visual acuity, rest of anterior segment evaluation and fundus were also within normal limits. This slide shows mild restriction in the lateral gaze, right lateral gaze, dextro elevation and dextro depression. MRI was done. MRI revealed an infiltrative midline mass measuring 45 into 52 into 43 arising from the left thalamus and dorsal midbrain in the figure 2. The lesion caused obstruction of cerebral aqueduct and lateral ventricles, which can be seen in the figure 3, with the mass effect resulting in displacement of right thalamus and adjacent midbrain structures. The child was referred to neurosurgery, where she was diagnosed diffuse midline glioma and underwent surgical decompression of the lesion with autologous cranioplasty. Histopathological analysis confirmed the diagnosis of diffuse midline glioma involving the left thalamus. Following the surgery, the patient received the 5 cycles of radiotherapy. On follow-up evaluation, ocular alignment was restored to orthophoria with preservation of good visual acuity, indicating a favorable functional outcome despite the presence of infiltrative midline tumor. Isolated 6-nerve palsy in children can arise from a wide spectrum of causes, including vascular, traumatic, inflammatory, infectious, neoplastic, and idiopathic etiologies. Unlike adults, where microvascular causes are more frequent, pediatric presentation often suggests more serious intracranial pathology. Thorough evaluation is therefore essential to avoid delayed or missed diagnosis. In this case, a comprehensive ophthalmological assessment provided the initial clue, while neuroimaging confirmed the presence of an infiltrative midline glioma. Early identification allowed timely neurological intervention and adjuvant radiotherapy, ultimately leading to preservation of vision and orthophoria, highlighting the value of multidisciplinary management in such presentation. Prompt evaluation and timely referral provided in facilitating accurate diagnosis and effective management in this case. These two images present the pre and post treatment. In pre-treatment, we can see 15 degree of esotropia in primary position at the initial presentation, and post-treatment orthophoria was attained. Thank you.
Any question? So if the 6-nerve palsy is due to raised ICP, what would be the presentation?
In the fundus examination, we could find papilledema.
Any other finding? Your presentation is unilateral. In raised ICP.
It can be bilateral.
Yeah, it can be bilateral. Thank you.